Good morning all. Today's topic is temporomandibular joint ankylosis. Temporomandibular joint is a diarthroidal ginglymus joint, that is, it has both hinge movement and translatory movement. It is also called a synovial joint because it is filled with synovial fluid that is capable of both rotational and translatory movements. So TMJ is a diarthroidal ginglymus synovial joint that is capable of both translatory and rotational movement. It is formed by the articulation of glenoid fossa of temporal bone and the head of the condyle. This is the head of the condyle and this is the temporal bone, and it's the articulation between the head of the condyle and the glenoid fossa of temporal bone. Then anatomy of TMJ, that is, the articulation of TMJ consists of a condyle. This is the condyle, then articular surface of temporal bone, then a fibrous capsule around it, then articular disc, then muscle and ligaments, and the ligaments include sphenomandibular ligament, spinomandibular ligament, and lateral ligament. This is stylomandibular ligament. This is the lateral ligament. This is the articular disc. This is the head of the mandible, that's a condyle. Then this is a joint capsule. This is a lateral pterygoid muscle. Then what is ankylosis? Ankylosis is a Greek word that means stiff joint. The joint will become stiff, become difficult to move. It refers to the partial or complete inability to open the mouth, which result in functional or growth deformities of the mandible. Ankylosis may range from simple fibrous restriction of jaw movement to a bone formation within the joint, restricting the movement of the jaw completely. And what are the etiology for this ankylosis? It can be either due to trauma or due to infection and inflammation or due to some systemic causes and other reasons. The trauma can occur during forceps delivery, intracapsular fracture, and congenital problems. Infection and inflammation can occur in case of otitis media, parotitis, and mastoiditis. And systemic causes include scarlet fever, meningitis, and smallpox. And other cases include post-surgical and malignancies and trismus. These are the etiology for TMJ ankylosis. What are the pathophysiology for TMJ ankylosis? How it occurs? When there is any fracture or an infection or something like that, there will be an intracapsular fracture of bone and bleeding occur within this joint cavity. And this bleeding is known as hemarthrosis. And the bone fragments within that region had very high osteogenic potential. And organization of hematoma occurs within the joint. And this hematoma converts into fibrous tissue. And this causes the ankylosis of TMJ. Classification of temporomandibular joint. There are many classifications are there. One is based upon the type of tissue that's causing the ankylosis. That is fibrous ankylosis and bony ankylosis. Sometimes the ankylosis may be fibrous, sometimes it may be bony. And based upon the side involved, unilateral or bilateral ankylosis. That is, in unilateral, only one side is affected, and in bilateral ankylosis, both the TMJ is affected. Based upon the severity of ankylosis, partial ankylosis, and complete ankylosis. Based upon the type of etiology for trismus, pseudo ankylosis, and true ankylosis. Another classification is classification by Casantian, that is intra-articular or true ankylosis and extra-articular or false ankylosis. Next classification is by Topazian. Here, Topazian had divided TMJ ankylosis into different stages in 1966. It is stage 1. This ankylotic bone is limited to condylar process only. In stage 2, ankylotic bone extends to the sigmoid notch. In stage 3, that is ankylotic bone extends to the cornoid process. It is stage 1, just condyle only, stage 2 up to the sigmoid notch, and stage 3 up to the cornoid process. Then next is Shawnee's classification, that is, he had classified the TMJ ankylosis as type 1, 2, 3 and 4. This is one of the important classification. It is type 1 is minimal bony fusion is seen here. Minimal bony fusion is seen, but extensive fibrous adhesion is seen around the joint. And stage type 2, that is a bony fusion occur at the outer edge of the articular surface, but no fusion on the medial area of the joint. Then type 3, a bridge of bone is formed between the mandible and the temporal bone. Then type 4, the joint is completely replaced by the mass of bone. Then diagnosis. How can you diagnose TMJ ankylosis? First, detailed history. That is, ask the patient about whether he had any history of trauma or any infection, any surgery, any tumor. Then complete clinical examination of TMJ should be done. Also, intraoral examination should also be done. Then photographs should be taken. Then investigation. Radiographic examination is done, which include facial CT scan or CBCT. Then OPG also helps in diagnosis. Then PA cephalogram, lateral cephalogram, and CT angiogram. These radiographs helps in the diagnosis of TMJ ankylosis. Then assessment of airway obstruction and obstructive sleep apnea. And clinical features for TMJ ankylosis. TMJ ankylosis can be either unilateral or bilateral, and it can be affected below 15 years and after 15 years. If it occurs below 15 years, there may be facial asymmetry. If it is unilateral. So, in unilateral ankylosis, clinical features include facial asymmetry, then affected side appears normal, and affected side appears normal, and the opposite side appears flat. The chin may deviate to the ankylosed side. Deep antegonal nodes may be seen, and reduced condylar movement on affected side. Unilaterally on affected side, reduced condylar movement is seen, and a class 2 malocclusion is noticed. And mouth opening will be decreased, and there will be a posterior crossbite and poor oral hygiene. Then bilateral ankylosis, that is, trauma occurs in both the temporomandibular joint. In such cases, a bird face deformity is seen and trismus is noted. That is very difficult to open the mouth. In class 2 malocclusion, deep antegonal notch, which is seen in both types, both unilateral and bilateral ankylosis, and poor oral hygiene due to difficult mouth opening, then crowding of teeth, protrusion of upper anterior teeth, then anterior open bite, and no condylar movements palpable. This is bird face deformity seen. Then Sequela for untreated ankylosis. It can cause untreated ankylosis can cause facial deformity, then speech deformity, nutritional deficiency, respiratory distress, malnutrition, malocclusion, and poor oral hygiene due to difficulty in opening the mouth. Then anesthesia for this TMJ ankylosis patient is very difficult because mouth opening is very poor. So the types of intubation for this kind of patient is one is awake blind nasal intubation, then retrograde intubation using guide wire, then awake tracheostomy, awake fiber optically assisted nasotracheal intubation, which is the gold standard, then fluoroscopy assisted intubation. Then there is a protocol for TMJ ankylosis treatment which was put forward by Cabans in the year 1990. According to Cabans' protocol, this is an important protocol. According to him, one is aggressive recession of ankylotic segment. Then ipsilateral coronoidectomy, that is one coronoidectomy done in one side. Then check for the mouth opening. And if there is no adequate mouth opening, then contralateral coronoidectomy is done if necessary. Then lining the joints with temporalis fascia or cartilage. Then reconstruction of ramus with costochondral graft. Then rigid fixation of graft is done. Then early mobilization and aggressive physiotherapy is done. Next is a modification of this Cabans protocol, that is TMJ ankylosis in children in 2009. According to him, aggressive excision of fibrous or bony mass, then coronoidectomy on the affected side, then coronoidectomy on the opposite side if the step 1 and step 2 do not result in adequate mouth opening of 35 millimeter. Then lining of the joint with temporalis fascia or native disc. Then reconstruction with either distraction osteogenesis or costochondral graft and a rigid fixation is made. Then early immobilization of the jaw if distraction osteogenesis is used to reconstruct the ramus and mobilize the day of the surgery. If costochondral graft is used, then early mobilization with intermaxillary fixation, not more than 10 days should be done. Then aggressive physiotherapy should be done. Approaches to temporomandibular joint. One is pre-auricular incision, next is post-auricular incision, then hemicoronal incision, submandibular incision, post-ramal incision, endural incision, retromandibular incision, and rightidectomy. This is the pre-auricular incision, that is in front of the auricle. This is a modification of pre-auricular incision, that is a Blair inverted hockey stick incision. This is Thomas angulated incision. This is Dickman incision. This is endural incision. Then Popovich and Crane incision, posterior auricular incision, and say submandibular incision. These are all modifications of pre-auricular incision. And this is also a modification of pre-auricular incision. This is Alcott-Bramley incision. This is a question mark shape incision. This is the endural incision. Next is post-auricular incision, that is behind the auricle. This is the post-ramal incision. And management of TMJ ankylosis. Three types of management, that is one is condylectomy, then gap arthroplasty, then interpositional arthroplasty. Condylectomy, this is done in cases of ankylosis where anatomic features of the joint are not completely changed, as in case of fibrous or partial ankylosis cases. This condylectomy is done. That is, an incision is placed and the condylar region is exposed. A horizontal cut is made at the region of the neck of the condyle. The head of the condyle is sectioned at the level of this neck and carefully separated. Since the superior attachment is not firm, it may be detached and the entire head of the condyle is separated and removed. The stump of the condyle at the neck is smoothed, and thus a new joint is created here. This is the cut made the condyle, and later it is smoothed. It's complication for condylectomy. One is loss of vertical height of the ramus, and in case of bilateral condylectomy, it may create an anterior open bite. In unilateral cases, there may be deviation of jaw on opposite side on opening. And gap arthroplasty. A gap arthroplasty involves creation of an anatomical gap in the ankylosing segment to form an artificial joint space, commonly done in case of complete ankylosis. That is, condylectomy is done in cases of partial ankylosis, and this gap arthroplasty is done in cases of complete ankylosis. A gap in the bone is created to separate the ramus from the ankylosed mass in the glenoid fossa. Two horizontal bony cuts are made in the most superior aspect of the ramus, and the wedge of a bone between these two cuts are removed. Care should be taken while removing the bone from the medial aspect, as it is close to the maxillary artery and carotid canal. A gap of about 1 to 1.5 centimeter is created and not interposed with any material. The mouth is forced open with the help of a mouth gag. The gap should be maintained by active physiotherapy of the joint to prevent re-ankylosis. When the adequate movement cannot be brought out, it may be required to osteotomize the coronoid process also. The complication of gap arthroplasty is it is difficult to remove the actual extent of the ankylotic mass as it is not properly assessed medially. The chances of creating excessive gap and reducing vertical height of ramus occurs when anterior open bite occur due to excessive bone removal. The re-ankylosis can occur between the cut edges. Next is interpositional gap arthroplasty. In this, similar to gap arthroplasty, a horizontal cut of 1 to 1.5 centimeter is made, but here an interpositional material is placed in between the gap. That is, when gap arthroplasty is done to release ankylosis, there are chances of contact between the bone ends and re-ankylosis occurs. So, an interpositional material is placed in between them to avoid contact and minimize the chance of re-ankylosis. Materials which can be used are either alloplastic or autogenous material. Procedure involves creating a gap and then inserting an interpositional material and stabilizing it. This alkyd family incision is made and opening done. The material used for interpositional gap arthroplasty are one is alloplastic material, which include metallic and non-metallic substance like non-metallic is elastic, acrylic, Teflon, ceramic. Metallic like tantalum plates, stainless steel, titanium, gold. And autogenous materials include costochondral graft, metatarsal graft, sternoclavicular joint, articular jaw, auricular cartilage, temporalis muscle, fascia lata, and dermis graft. And complication for this interpositional gap arthroplasty is one is foreign body reaction. Next is difficulty in suturing from the medial aspect. Another one is a second surgical site is needed. Another complication is other complication of gap arthroplasty. Then causes for recurrence for TMJ ankylosis. One is improper or inadequate surgical resection. Next is fracture of costochondral graft. Another one is important graft fixation. Then inadequate physiotherapy. Next, increased osteogenic potential of the resected segment. Post-operative physiotherapy is very important. Encourage the patient to start active exercise of the jaw as soon as it can be tolerated. Initially, pressure with finger or simple finger exercise to gently force open the mouth. Later, ice cream stick, tongue blade, mouth gag can be used for forceful mouth opening. And medications can be given to relieve pain and enable movement. Heat application to the region prior to exercise permit easy movement to relieve muscle spasm. Thank you.